50 slides of cardio stuff. I just tried to come up with just based on like all the practice questions I've done and what we've seen. I mean, you've seen it too in the hospital now. Like what's most likely going to show up on your step exam. Obviously, I can't ask about anything. We'd be here for the whole day. We'd be here for 24 hours if I wanted to cover every cardio topic. But trying to keep with the most high yield ones. Some like tips like while you're going forward with like your answering questions, I tell this to every student. Like again, like try to read the last line of the question first. What are they actually asking me? I go back and I read the vignette, and so I read the last line, and they're like, what is the diagnosis? So then I read the vignette and I think to myself, okay, I need to come up with a diagnosis before I answer the question. If they're only asking me what's the next step in management, I don't need to spend all my time like doing the nitty gritty and trying to be like, all right, is this like NSTEMI? Is this UA? Is this like, oh, like I don't like in general, if I have my general idea, I can come to the right answer, move on. Obviously in real life, we're always going to want to come up with a diagnosis, but when we're doing these, stupid standardized exams, time is money. And so just being able to kind of do things as quickly but efficiently as possible is also going to really help you. And then the better you get, I want you guys all starting to work towards not looking at the answer choices first and trying to come up with the answer on your own, and then match your answer in your head to the best answer that's provided, right? Like, because MBME, they're so good at their professional test writers, they know exactly the wrong answer choice that students are going to pick. To defeat that is I read the STEM and I'm like, oh, like this is STEMI, right? They're asking me what the next step in management. And I go through my head, I'm like, all right, what would I do for a patient with STEMI? I would do this, this, or this. And then I look at the answer choices. I'm like, all right, there it is. Boom, done. I just make sure the other 4 answer choices or whatever aren't any better. I cross them off and I move on. Sometimes NBME, they're tricky and they write the answer choices in ways like you couldn't predict. In that case, you just have to critically think and read through them. But the better you get at that now, the better you're going to do on step 2. The better you're going to do in real life, because as you've seen, you don't get multiple choices in real life. So we'll work on that now, and then we'll continue. Like that's a never-ending skill. So to start, I want you to think about what are the 4 pillars of heart failure for reduced ejection fraction. So there's 4 main classes of medications we usually use with HFrEF. How do those pillars change if the patient has HFpEF, so preserved ejection fraction? And then also think about what are some of the first-line antihypertensive agents. Take as much time as you need, and then whenever you're ready, we'll discuss.
Okay. Well, let's start with first-line hypertension agents, because that's
Okay.
a little bit easier for me. Definitely ACE or ARB is like
Yep.
pretty much first line. Like that's the first thing. And then thiazide diuretics are pretty high up there. So like start with a thiazide diuretic, but then like we could go depending on their fluid status, like to something stronger, like loop diuretic for sure.
Yeah, so like I agree. So there's 4 main types of like first line antihypertensive. There's thiazides, and really the best studied one is chlorthalidone. Hydrochlorothiazide is also effective, but chlorthalidone, as of the data we have right now, is like the most effective. So those 1 class, thiazides. ACE, 1 class, beautiful drug. ARBs, 1 class, beautiful drug. And then usually like dihydropyridine, calcium channel blockers, so like amlodipine, nifedipine. So those are going to be like your big 4. Usually starting with like a thiazide is the go-to. But when would you consider starting a patient on like an ACE-I or an ARB instead of a thiazide?
If they have renal disease, then it's definitely useful.
And especially you want to think about like diabetic nephropathy, right? So if they tell you in the STEM, the patient has type 2 diabetes, type 1 diabetes, they've got albumin in their urine, and they have hypertension. Even if they don't have hypertension, really like data is showing, start them on an ACE-I or an ARB, right? We have to just be careful, right? If they have any kind of reactions to an ACE-I, right? Like the big ones are going to be angioedema and the cough. consider an ARB, right? Those have less of an effect. But those are just some things to consider when you're reading a question. Tell me, what are some side effects of thiazide diuretics?
So it's elevates glucose, so kind
Yep.
of negative for diabetics. Uric acid is increased, calcium is increased. Oh gosh, and then it's should be something with an L.
Yep. Lipids. So, yep. So
There
like
we
that,
go.
that mnemonic I think you're
Hyperlipidemia.
thinking of is hypergluc. So hyper meaning elevated, then the gluc, the G is glycemia, L is lipids, U uric acid, C calcium. Right. All things to consider. And then the big side effect with the dihydropyridine calcium channel blockers will be peripheral edema. Right. All things easily tested, easily things you'll see in real life. Um, Loop diuretics aren't really used to control hypertension. Those are used more for fluid overload, like volume overload, which, yes, if the patient is like overtly volume overload, will probably contribute some to elevated blood pressure, but it's not really considered like an antihypertensive agent. So you'll see like if a patient is on something like furosemide or a beta blocker or like that, and they tell you, oh, like this is to control my blood pressure, like yes, but you should also then like dig in more. Okay, what other medical conditions do these patients have? Because those aren't first line antihypertensives, and whoever started them on it had a good reason for it, probably because they had a comorbidity, right? So that's how we can kind of like if the patient has. This is another like classic question. You guys didn't take shelf exams, but like on the family med exam, the shelf exam, there was at least like 5 or 6 questions asking which antihypertensive to put the patient on, and they would always be like a patient with a comorbidity, right? So it's like a patient with like stable angina who also had hypertension. Okay, put them on metoprolol. Patient with diabetes with hypertension, put them on an ACE-I, right? So thinking like that. Okay, antihypertensives. All right, what do we got for the 4 pillars for HFrEF?
Okay. So I know heart failure in general, don't know the difference
Okay.
between the two, but it should be an SGL2
Mm-hmm.
inhibitor, a beta blocker, a mineralocorticoid, and an ACE ARB.
Yep. So
Yeah.
absolutely. So it's going to be SGL2 inhibitors, mineralocorticoid receptor antagonists, beta blockers, and then ACE-IR ARNI. Okay. With regard, I'm just going to dig in a little bit more. With regards to beta blockers, do you know which 3 beta blockers have been proven effective in HFrEF? There's 3 specific ones.
Okay, I'm gonna say metoprolol.
Can you be more specific? There's two big types.
Yeah. Succinate.
Yep, because it sucks to
And
have heart failure, right? So metoprolol succinate is one of them.
I want to say it's
Yep,
bisoprolol.
bisoprolol.
Then maybe carvedilol.
Yep, absolutely. Banged them right on the head, right? So the reason I ask that is because MBME is getting really good, and they will put a patient with HFrEF, and they'll say, which of these drugs should we put? And they're all going to be like beta blockers, or like 3 of the answer choices will be beta blockers, and you're like, which one? Right? It's got to be one of those ones: metoprolol, succinate, bisoprolol, or carvedilol. Okay, so that's one. We already talked about. There's the beta blockers, the mineralocorticoid receptor antagonist. Do you know like the 2 major types?
Spironolactone and
Yep.
eplerenone.
Yep. And working maybe in the near future, finerenone is going to be on that list too. The SGL2 inhibitors, the 2 big ones are dapagliflozin and empagliflozin. Um, there is campagliflozin, but these 2 have been proven better. And then with regards to like the last class, ARNI is always preferred over ACE-I or ARB. That's because ARNI has been proven even more effective in reducing mortality and in getting the patients out of the hospital. But sometimes patients are just started on an ACE-I or an ARB. You keep them on that until you can transition to an ARNI. What's the mechanism of an ARNI?
Okay. It adds the neprilysin
Mm-hmm.
inhibitor. I don't exactly remember what that does
Yeah.
though.
So the neprilysin is what breaks down your like atrial natriuretic peptide and brain natriuretic peptide. Atrial natriuretic peptide release from atrial stretch, BNP release from ventricular stretch. Those do a lot of things. One of the big ones is they go down to the kidneys. They cause afferent arterial dilation. They help the kidneys pump out more water. They help us excrete more water. The problem with heart failure is we get all this fluid overload. It leads to activation of my renin-angiotensin system, and we get deleterious cardiac remodeling. So the ARNI, what it does is the valsartan part will block the ARB. It will block, or it's an ARB. It'll block angiotensin, right? So we block some of that cardiac remodeling. The sacubitril part blocks neprilysin. So we keep more BNP, ANP in my system, which allows more afferent arterial dilation, which allows us to excrete more water to reduce the fluid overload. So it's kind of that combination right there that kind of has made it a better drug. HFrEF, we usually define as an ejection fraction less than 40. HFpEF, we define it as an ejection fraction greater than 50. In between, there's a couple different terms for them. Some call them like moderately reduced ejection fraction. Not going to be tested on step 2. For step 2, no HFrEF less than 40, HFpEF greater than 50. For HFpEF, really just SGLT2 inhibitors are mainstay. MRAs and ARNIs can be considered, but SGLT2 inhibitors are going to be like go, go, go. These have proven effective even in patients without diabetes. There's really no pharmacotherapy in HFpEF that's demonstrated a mortality benefit, but your SGLT2 inhibitors are going to be have the strongest evidence for reducing hospitalizations. All right. So like that's another key question is as of today, HFrEF, these 4 bad boys all have reduced mortality. In HFpEF, none yet. Hopefully, we'll get some data soon. And then you have drugs like your loop diuretics and your digoxin and things like that are good for symptoms, but they're not going to reduce mortality. So just be very careful when you're reading the questions. Are they asking me about mortality? Are they asking me about symptoms? And go from there. I think these are easy questions when if I can just remember these 4 classes of drugs, only one of them can possibly be in the answer choice. Otherwise, it wouldn't be a fair question. You just pick it out and you move on. We talked about the first line. What's special about carvedilol's mechanism of action? And then side effect profile, what's the difference between spironolactone and eplerenone?
So for sure, carvedilol is a non-selective
Correct. Yep.
beta blocker. So beta
alpha
1
and beta.
two.
Absolutely. Yep. No, yeah, you got it. Yep. Beta 1, beta
Okay.
2, and alphas. Yep.
And then side effect profile, the big thing is spironolactone can cause gynecomastia. So
Yep.
that's pretty negative for most men.
Absolutely right. So carvedilol, alpha and beta blocker, spironolactone decreases androgen production and blocks androgen binding. It favors estrogen, can lead to gynecomastia. Spironolactone is like dirt cheap. Pleuronone is a lot more expensive, so you just weigh the risks and benefits. But be on the lookout. That's an easy question to get on step. We'll move on from there. All right. So I'm asking you, what's the next best step in management? We have a 68-year-old man with a history of heart failure with reduced ejection fraction, presents to the emergency department with acute onset dyspnea, orthopnea, peripheral edema, and jugular venous distension. His vital signs are stable. Physical exam reveals pulmonary crackles and an elevated JVP. What do we do next?
Oh yeah, start furosemide. He's
Absolutely
volume
right.
overloaded.
Yep. So very easy. It can get tricky when they also offer you like metoprolol because you're like, wait, like metoprolol can be used for heart failure. We never use metoprolol in an acute heart failure exacerbation, right? Because given its mechanism of action, it actually reduces the heart's ability to pump, which is actually going to lead to more volume overload in this case. So it would be a great drug to start on this patient once we kind of get them to a stable point, but not good in an exacerbation. In an exacerbation, we need to start a strong loop diuretic, all right? We don't use steroids. They're not infected. NIPPV, do you know when we use that?
That'd be like respiratory failure. Yeah.
Yeah, we usually see it in patients with acute exacerbation of COPD with hypercapnia. We can often start NIPPV, which will try to blow the alveoli open a little bit more. If that doesn't work, then we can progress to intubation. So it's kind of like a step before intubation. But yeah, you see a patient in acute exacerbation of heart failure, think loop diuretics, click it next. How do we know when to stop or slow down the IV diuretics? And then how do we know what do we do if the furosemide is not working?
So you're gonna watch basically on internal medicine. They're like told me you basically want to get to an AKI, right? You're watching for their bicarb and their creatinine. Once you see like the bicarb and the creatinine start to bump, you know they're too dried out, so you need to stop. Okay. There's a stronger drug than furosemide, and I don't actually remember at this point.
Yeah, no, so there's kind of like three of the loop diuretics. There's furosemide, torsemide, and butenamide. I can't say that one. Like really in like the spectrum of it, butenamide and then torsemide and then furosemide. So like 1 milligram of butenamide is equal to 20 milligrams of torsemide, which is equal to 40 milligrams of furosemide. So you were spot on for a patient like signs of slow down diuretics, metabolic alkalosis, secondary to volume contraction. They're down to their dry weight, so you can often look in the patient's chart. What is their usual dry weight? When were they last discharged? What was their weight? Elevated creatinine and BUN. Remember, if we're pre-renal, it's usually a BUN to creatinine ratio of about 20 to 1 or greater. And actually, that's like the literature shows not the best test, so we can get a fractional excretion of sodium, which would be less than 1, which would be key me in on a pre-renal. If the urine output starts decreasing and then their volume status are improved. This is the big one that's going to show up on STEP along with this, okay, if they wanted to ask you. If the IV furosemide is not cutting it, we can try up titrating. We can try switching to a different loop diuretic. But the other thing you have to consider is if the patient's been on chronic diuretics, they can get what's called diuretic resistance. That's because when we give them a loop diuretic, right, where does the loop diuretic work?
In loop of Henle.
Yeah, the thick ascending limb of the loop of Henle, right? It blocks the sodium potassium 2 chloride channel, right? And so right next to the loop of Henle is your distal convoluted tubule. You have a patient that's been put on a loop diuretic for many years. Their distal convoluted tubule gets really smart and it gets really efficient at reabsorbing that sodium. And so normally, if I just put you or me on a loop diuretic, all that sodium we're blocking, it's going to get peed right out and all the water is going to come with it. In a patient who's been on a loop diuretic for many years, a lot of that sodium is going to get reabsorbed by the distal convoluted tubule, and us giving them the loop diuretic isn't going to do much. So what we can do is it's called sequential blockade. We give them a distal convoluted tubular blockade, right? So we give them a thiazide diuretic, which blocks the DCT. And so now we block both the thick ascending limb and the DCT, and we've kind of stop that reabsorption of sodium. So that's something that I've seen tested. It's a good option. The other thing you want to consider is in patients who are overtly volume overloaded, giving them an oral diuretic is not the best bet because the patients will have a lot of gut edema, which really decreases the bioavailability. So again, when you're reading answer choices, they could have multiple different diuretics on there. Look and see, are they clarifying? Are some of them IV? Are some of them oral? Right off the bat, I can eliminate my oral options, right? Not a good option. The other thing you want to consider is furosemide has a bioavailability, even IV, a bioavailability like 10 to 90%. Your butenamide, bumetanide, and torsemide have like a bioavailability above 80%. So like furosemide, it's really like hit or miss. Is this going to work or not? So all things to consider. Does this make sense?
Yeah. Mm-hmm.
Okay. All right, next question. So I'm asking you, what's the next best step in diagnosis? We have a 32-year-old man with newly diagnosed classical Hodgkin lymphoma. He's receiving standard combination chemotherapy. He presents to the emergency department with acute onset dyspnea, orthopnea, and bilateral lower extremity edema. On exam, he's tachycardic, elevated JVP and bibasilar crackles. His blood pressure is 110/70, oxat 92. He has no prior cardiac or pulmonary history. What do we do next?
Yeah, definitely echocardiogram. It's
Yep.
probably the chemotherapy causing like dilated cardiomyopathy.
Absolutely. Yep. And so, like in this case, very similar to the previous, right? But instead of talking about like interventions, I'm asking you more about like imaging wise, right? So you hit the nail on the head here. Hodgkin's lymphoma. Do you know what the chemotherapeutic regimen is like for classical Hodgkin's?
No.
You did you get it, you got it right. Like, so one of the drugs is classically linked to dilated cardiomyopathy. So we usually use ABVD. So A is adriamycin, which is another name for doxorubicin or an anthracycline. B is bleomycin, V is vinblastine, and D is dacarbazine. So what you kind of know, like chemotherapies were huge on like step one, like all the side effects, still huge for step two. I'll tell you, like in general, like the chemos and the cancers aren't like a huge emphasis, but they still make up like 5, 6, 7 questions on your exam, which can mean a difference between a couple points on your exam, right? So it's your adriamycin or your anthracycline that's going to probably cause the dilated cardiomyopathy. Your bleomycin is classically linked to pulmonary toxicity, like pulmonary fibrosis and restrictive lung disease. And then your vinblastine classically can cause the peripheral neuropathy and diarrhea. So all things to consider. So absolutely, we have a suspicion for heart failure. We want to get an echo. We usually do transthoracic, right? We can do that outside the chest, non-invasive. We can get a pro or an NT pro BNP, which we'll talk about in a second, which will likely be elevated. Let me think here. I think that's what I wanted to say on that. Yep. Which other chemotherapeutic agent that you know of, at least for step one, step two, is linked to dilated cardiomyopathy?
That's a good question.
Think about breast cancer.
I don't know. I'm not up on the
That's
not
okay.
up on the chemotherapy agents.
Trastuzumab. Does that sound familiar? It's a HER2 blocker.
Okay.
Trastuzumab. So another way I've seen them ask this question is they'll ask you, like, the patient is put on trastuzumab or they're put on an anthracycline, and they'll say which other chemotherapeutic agent should not be added or has a similar side effect profile, X, Y, or Z. Okay. So those are the big ones to know. So transthoracic echo, that's what we wanted to get at here for a diagnosis of new heart failure. All right. Even though this isn't a like hemonc unit, just because it's really high yield. Do you remember, like, so for nodular sclerosing Hodgkin lymphoma, the most common, if I did a biopsy and flow cytometry, what would I see?
Reed Sternberg cells.
Yep. So Reed-Sternberg, which look like the owls, and what would you see on flow cytometry?
Oh, like what? Cell markers.
Yeah, CD what?
It's B cells. So
Yeah.
that's higher, like CD20.
So this one's actually not CD20. So your non-Hodgkin's lymphomas are classically CD20. Your Hodgkin lymphoma is classically CD15, CD30 positive. Right.
Okay.
Again, yeah, like, so we can do a whole lecture on hemonc at another point. I'll tell you again, like the cancers, not super high yield, but if there's going to be one that I want to go into step two, knowing it's probably Hodgkin, I would say like Hodgkin's lymphoma, CLL, and CML, and maybe I'd throw in like a diffuse large B cell lymphoma. If I know those ones pretty well, those are probably what they're going to ask me about, because those are very common and very commonly tested. That story for another day. All right. So going on, we talked a little bit about the ASI and RNAs. So if we want to know what must be done first. We have a 64-year-old man with HFrEF, ejection fraction of 30. He's stable on lisinopril, metoprolol succinate, spironolactone, and furosemide. We want to switch his ACE-I to sacubitril valsartan. What must we do first?
Oh, okay. So we're changing. He was on ACE, but now he's gonna be on the
Yep.
ARB. Okay, so we don't want those to overlap. So we want probably C. Allow
Yep,
the
very
ACE to
good.
wash out.
Yep. So we want at least a 36-hour washout. We are worried about the angioedema risk, right? So give him 36 hours. Um, this is what I was getting at: is Arnie's increased BNP level. We already talked about that. That's literally their MOA. So in these patients, I've seen questions on this. They'll give you a patient who's on an Arnie who's not in overt heart failure right now, and their BNP is like sky freaking high, and they'll ask you why, and the why is because that's the mechanism of action. What we need to do is we need to track the pro NT BNP, right? So the pro N terminal BNP. This is not influenced by Arnie. So if you think about back to your internal med days, even if you didn't recognize it, like all the tests you would get on a patient with heart failure who was admitted to the hospital was always the pro NT BNP. It was never the BNP, and that's because this is not influenced by drugs. Um, I just want you to also be aware because they can ask about it and it's things you want to know, especially if you want to go into like family medicine because you'll see this a lot. We can have elevated BNP just like troponins for reasons other than BNP being an acute exacerbation of heart failure, troponins being acute coronary syndrome. So big ones to consider are going to be a patient with CKD, right? We can't renally excrete this BNP. If a patient has some sort of myocardial infarction, and then on the flip side, BNP can also be lowered in obesity. So you could have a patient who's morbidly obese, they're an acute heart failure exacerbation, but their pro-NT BNP is within normal limits. That's because obesity in itself lowers the BNP level. Does that make sense?
Yes. Yeah.
All things to consider. All right. Next question. We want to know next best step in management. Patient's diagnosed with HFrEF. He's got an ejection fraction of 22%. This occurred after a recent MI. He was started on the 4 pillars of therapy and was up titrated to the max tolerable dose of each one. A repeat TTE 4 months after his infarction demonstrates an improved ejection fraction to 24%. What do we do now?
Oh, okay.
This one's hard. It's more of an
Honestly,
advanced concept. Yep.
yeah. It's probably something about like the ejection fraction being as low as it is. I don't know. I'm kind of between A and B, leaning
Mm-hmm.
towards A because like
You reasoned through that perfectly and you got it right. So it definitely is a so what you need like so first off, like this is great. Like this is a great teaching moment because even though you didn't know the exact guidelines or the exact indications to place an ICD, you can reason through it and you're like, well, his ejection fraction is 24%, which is terrible. We probably need to do something about it. Considering he's been on all 4 pillars, we up titrated them to the max dose. He's been on them for 4 months and his ejection fraction only went up 2%, and it's still very low. We probably need to do something, right? Just continuing to watch is not going to do anything. Digoxin is like almost never the right answer for like any step question. Almost never the right answer, right? Unless they're asking you about digoxin toxicity, which is a story for another day. But digoxin is like never the right answer. He's got no chest pain. I've got no concern for a reinfarction. I don't need a cardiac cath. And cardiac MRI, we really only do like if an echo is unrevealing or I suspect some sort of like infiltrative cardiac disease like sarcoid, amyloid, hemochromatosis, things along those lines. No need for that. So what you need to know going into step 2 lamb is if the patient has been on max titratable, like max tolerated of the GDMT, goal directed medical therapy, for at least 3 months, all right, and his ejection fraction is still less than or equal to 35%, that is indication to place an ICD. So really, like if you look at the guidelines, they say at least 40 days post MI and after a minimum of 3 months of optimized GDMT. So really, like I don't know why they even say at least the 40 days post MI, right there. Post MI, I need to wait at least 3 months while the patient is on full doses of the GDMT or max tolerable. They don't have to be all the way up, but just whatever the patient can tolerate. If the ejection fraction is still less than 35%, we're going to place an ICD. The reason for that, right, when you have ejection fraction so low, it just predisposes us to ventricular arrhythmias, and the patient can die, right? So does that make sense to you?
Yeah. Would there be times when somebody hadn't had MI and their ejection fraction is less than 35%, you still place ICD?
Yep. Yeah. And so like I've seen this now 2 or 3 times on the wards is a patient will come in with, for some reason, having an acute exacerbation of heart failure, or we newly diagnose them. They have an ejection fraction of like 15%. At that case, right? That's a conversation with like cardiology. But if they've been on GDMT for at least 3 months, like that right there is an indication to place a pacemaker or sorry, an ICD. What they'll give you on the exam, if they want to ask about this, is the patient has heart failure for whatever reason. They've been placed on all 4 pillars. They've up titrated them. It's been 5-6 months. Their ejection fraction's barely gone up. What do we do now? We place an ICD.
Great.
All right. So again, like this was kind of getting at your last point. What are some common causes of HFrEF? Right. Ischemic is going to be really one of the bigger ones. We always need to check for ischemic cardiomyopathy. So you do that with cardiac cath, or CCTA can also be used. Cardiac cath is gold standard. Long-standing hypertension, valvulopathies like aortic regurg, mitral regurg, tachyarrhythmias, so like poorly controlled AFib, poorly controlled aflutter. The heart's just pumping way too fast. Eventually, my ventricles die out. Toxic. We've already talked about anthracyclines. Alcohol is a huge one. Think about your viral and your myocarditis, right? Myocarditis, especially in younger, healthy patients, might be more transient. You get a patient who's 70 years old who gets a bout of viral myocarditis, that might be permanent. Peripartum cardiomyopathy, either during pregnancy or shortly after giving birth, usually within the first like 4 to 6 months. You want to be on the lookout for this, right? It's a classic question for step 2. So you look for a patient who recently gave birth and now is coming in with all the signs of heart failure that we've literally described. Be careful. Another question I've seen on this is, what if the patient wants to get pregnant again? Do you know what you tell them?
Yeah, they have to wait.
They have to wait,
They have
and
to
really,
wait.
there's very few instances where you would probably be okay letting them get pregnant again. The best answer on a standardized exam is probably, unfortunately, like you're not gonna be allowed. Not like you have control, but like you're gonna strongly urge them not to get pregnant again, because if they do get pregnant again, the patient could die, right? And then there's infiltrative, right? We'll talk about in a second. That can cause both HFrEF and HFpEF. And then causes of decompensation. If the patient's having a poor diet, right, they're eating all salts, they are not using their medications, they have AFib with rapid ventricular response, acute coronary syndrome, uncontrolled hypertension, anemia, thyrotoxicosis, NSAIDs. What is this drug? Thiazole. I can't even say it, but do you know where we use this one? It's not really used much anymore, but
No, I would just think thiazide diuretics, but
yeah, these are also called glitazones. That's how I call them.
The
those are
PP4 inhibitors, is that it?
Yeah, they're
Yeah.
along those lines. Those are the gliptins that are the PP4s. These are slightly different, but these are used in
Okay.
diabetes. Not really as much anymore, but their main side effect is fluid, like volume overload, which would obviously be bad in heart failure. Um, all right, so those are common causes of HFrEF. Keep these in the back of your mind, because they'll often ask you on a question, what was the most likely cause of this patient's heart failure? And you can easily, like, if you read the vignette and you're familiar with some of these common causes, you can pretty much reason through what do you think caused it. And then some of the like weird testable causes of restrictive cardiomyopathy. Restrictive cardiomyopathy classically more causes a HFpEF type picture. So like HFrEF is ventricular, is the ventricle's not pumping as well, right? So we'll classically see, like if it's dilated, we'll classically see like an S3 sound, which tells me there's volume overload. The ventricle is able to accept volume, it just can't pump it. For HFpEF, it's more of the opposite, right? It's more of a diastolic picture. We'll classically see more of an S4 sound if it's restrictive cardiomyopathy. That's due to ventricular noncompliance. That's because the ventricle can pump totally fine, the ejection fraction's fine, but it can't expand, it can't accept volume. And so when I think about things that can cause like restrictive cardiomyopathy, it's usually infiltrative disease, right? So hemochromatosis can cause both. But absolutely right. If iron deposits into the heart, can absolutely cause restrictive sarcoid, amyloid, autoimmune diseases like scleroderma, lymphoma, eosinophilic, Fabry, glycogen storage disease. These are all like these are you know you're taking a 320 question exam. There might be one question on your exam. It's one question that you can get right if you can recognize it. I won't tell you which one of these, but one of these, it was one of the last questions on my exam. It was definitely a very tough question. There are just like some very, very subtle signs in the vignette that keyed me in on one of these diseases. And they ask, why does this patient have heart failure? And then you have to answer it was one of these, right? So things to keep in the back of your mind. And remember, hemochromatosis can be primary. It can be due to the actual genetic mutation in the HFE, the C282Y gene mutation, or it could be a patient that's getting chronic transfusions because they have sickle cell or thalassemia, and we're just giving them iron all the time, right? So that's something that students don't realize. It's something that shows up on exams all the time. If they're getting chronic transfusions, that iron is literally going to deposit just like in primary hemochromatosis. They're going to get restrictive cardiomyopathy, they're going to get liver damage, they're going to get pancreatic damage, and they could get pan-hypopituitarism too. All right, keep it moving. So acute coronary syndrome, what is our time frame in which we would like to get a patient from the door to the balloon? What do we do if we can't get them to a PCI in a reasonable amount of time? And then, so actually, we'll start with that first. Think about that, and then we'll go to the next question.
Yeah, 90 minutes door to balloon.
Yep.
And then, I mean, you can do TPA if
Yep.
you can't get them there.
Yep. So it's like 90 minutes is perfect. You'll see in like literature, 90 to 120 minutes. We always shoot for 90 minutes. And again, the perfect answer on an exam, if they're not going to be able to get to a PCI facility in time, you give them TPA or tenecteplase, one of those fibrinolytics. Okay. What other medications should be administered as we are considering? So we've got the EKG, we see STEMI, we see their troponins are elevated and they're uptrending. We're like, yep, this is acute coronary syndrome. It's STEMI. What other things should we give the patient while we're getting them to the cath lab?
Okay. My main thought would be nitro so that you can open up those vessels.
Yep.
If there is the ability to get past that clot or not. But
What else? Think about if a patient has a heart attack, what do you hear the EMTs always tell the patient? Do you know? Usually chew on something.
Oh yeah, and aspirin.
Yep.
Yes.
So we'll give them aspirin. We'll give them a lot more than just the chewable 81. We'll give them 325 milligrams of aspirin. If this is an acute coronary syndrome with a STEMI and we're going to the cath lab now, we'll give them unfractionated heparin because that works now, and it's got a reversible agent, right? Do you remember what the reversible agent is for heparin?
Dang, I got asked this on my surgical rotation. Didn't know it then. Clearly did not learn.
No, that's all right. This is a hard one. It's protamine sulfate. And so we can give that and we can turn it off, right? So we can turn it on, turn it off. If the patient has acute coronary syndrome secondary to unstable angina or NSTEMI, and we admit them to the hospital and we decide we're going to do cath lab tomorrow, right? Because like NSTEMI and UA are managed slightly different than STEMI, right? STEMI is ASAP now, NSTEMI UA, most of the time we can kind of take more of a conservative approach and do cath lab in a day or two, right? And in that case, we'll usually use like enoxaparin or a low molecular weight heparin. It's got slower onset. It's not as easily titratable and it's harder to turn off, but we don't need it to work like ASAP, right? So that's kind of that. Other things we would consider is usually after PCI, sometimes before, but usually after. We'll give them like clopidogrel or a P2Y12 inhibitor. It's really at the discretion of the cardiologist whether to start it before or after. The thing you're going to want to know for step 2 is if we do a PCI and we put a stent in, right? Either drug-eluting or a bare metal stent, for at least a month, the patient is going to be on dual antiplatelet therapy, right? Aspirin plus usually clopidogrel or a P2Y12 inhibitor, all right? It's at least a month for a bare metal stent, but it's going to be at least 12 months if it's a drug-eluting stent, all right? So that's like a really common and a very fair question. Any kind of stent place, it's going to be aspirin plus clopidogrel. Don't fall into the trap of picking like warfarin or something like that, all right? Aspirin plus clopidogrel. Other things we can consider are going to be an ACE inhibitor and a statin. So those aren't going to be like, do I need them before they go to the PCI to the cath lab? No. If we can start them, sure, but not like super necessary. We can also consider metoprolol succinate, which can be used, right? We'll talk about when not to use it. But again, is that like absolutely necessary? Meh, it's like hit or miss. And then we can consider morphine. We can consider oxygen. The data on morphine actually shows that it reduces the absorption of some of my P2Y12 inhibitors. So maybe don't give morphine. It's kind of up for grabs on that. But again, you hit it on the head. 90 to 120 minutes, we want to get them. If we can't, fibrinolytic therapy. Just be careful. If they have active bleeding, recent stroke, or severe hypertension, we're going to want to not give them fibrinolytic therapy. That's probably not step 2 land. That's probably more step 3 land. So you'll be probably fine. Again, we talked about antiplatelet therapy, aspirin, P2Y12 inhibitor, anticoagulation, beta blockers, statin, ACI or ARB, nitroglycerin, and oxygen. And then this is what we talked about. So at least 12 months for the drug-eluting stent and at least 1 month for the bare metal stent. All right, all good on that?
Yep.
All right, I'll make this bigger, but now tell me, so this is a STEMI. I'm already telling you it's a STEMI. You just need to tell me which kind of area of the heart, and if you can give me an artery, that would be the best.
So we got the elevations 2, 3, AVF. This is like the most common one. So I'm just going to go with the left anterior descending artery.
That's always a good guess, right? Because that's like the most commonly impacted. But unfortunately, 2-3 AVF is not usually the LAD. So this is an inferior STEMI. 2-3 AVF leads 2-3 in AVF. Pick up the inferior portion of my heart. The inferior portion of my heart is classically supplied by the right coronary artery in most patients, right? Sometimes you'll get patients that have kind of a mixed picture, or their left circumflex will supply, or their left coronary will supply. But really, thinking broadly, 2-3 AVF is inferior. and it's most likely the RCA, right? If it were LAD, it'd be more of my anterior leads. So it'd be things like V1 through V4. Sometimes V5, V6 get picked up. Sometimes you'll see one in AVL. Those are all like my left-sided leads, all right? Make sense?
Yes. Yeah.
So this is I picked this one for a reason though, because what else? Yeah, without me going to the slide, what else do you know about inferior stems? Like, what else should we look out for?
Okay, the inferior wall
Yep.
is like where the electrical conductivity is.
So what might you see
So
in this patient?
Probably more likely to have cardiac arrest.
Yeah. So you hit it on the head, right? The inferior portion of my heart, the RCA, supplies usually both the SA node and the AV node. If we're cutting off blood to that, right, there goes my electrical signals to the heart. The patient may have bradycardia, right, because we lose our electrical signals. And the right heart is extremely preload dependent. If we're losing blood supply to the right side of the right side of the heart can't pump forward, can't pump blood to the lungs, can't pump blood to the left side, can't pump blood throughout. So the patient may have hypotension as well, right? So things to look out for in a patient with inferior STEMI are also going to be bradycardia and hypotension, right? And so the reason I brought this up is because if you see bradycardia and hypotension in the patient, everyone always remembers like the monobash, which is exactly these drugs we talked about here. These guys here that we talked about. And they've memorized the Anki card, and they're just like, all right, anytime a patient has a STEMI, I just monobash them and we send them to the cath lab, right? If you gave the patient a beta blocker and diuretics or nitroglycerin in an inferior STEMI with bradycardia and hypotension, you will literally kill them, right? You're vasodilating and you're reducing contractility of the heart. You're making everything worse and you're going to kill them, right? So a classic question for inferior STEMI with bradycardia and hypotension, you give them fluids before you go to the cath lab, right? They're preload dependent, so you give them the fluids that they're missing, right? You pump the right side of the heart full of blood or full of fluid, right? Does that make sense?
Yeah.
Right. Classic question. I've seen that at least 10 or 15 times in my prep. So it very well could show up. All right. So now I want you to think about it. I'm going to show you another EKG. How does it differ? For context, this next EKG is a 25-year-old man. He's got left-sided pleuritic chest pain. It's quite bothersome while laying down. He had an upper respiratory tract infection 2 weeks ago. He's otherwise healthy to his knowledge. And here we go.
Okay. Well, here's the thing. I know he most likely has pericarditis.
Yep.
And I know that there's an ECG finding called like electrical altercans.
Okay.
And he's got but then I also just like these are just facts that I know, not necessarily the connections between them.
Mm-hmm. So I'll tell you, this guy does not have electrical alternons, and we'll talk about what that means in a second. So you're absolutely right, right? Sometimes I'll read a vignette and I'm like, I don't need to look at the picture or the X-ray or the EKG or the biopsy, whatever they give me. I just read the vignette. There's enough in it. I'm like, I know what it is, and I just use the picture to like confirm, right? That's how I would use this vignette, right? This is classic for pericarditis, which is inflammation of the pericardium, right? The sac around the heart. And classic findings will be pleuritic chest pain. So with inspiration, it causes stretch and kind of hits the pericardium, which causes pain. And then it hurts more when the patients lie down, and it feels better when they lean forward because it takes pressure off the pericardium. So that's kind of how you'll see that. So they'll often say the patient feels better sitting forward, but they'll also tell you the vice versa, right? It hurts when they lie down. You can also maybe appreciate a pericardial friction rub if the patient leans forward. What we see a lot of the times in acute pericarditis is diffuse ST segment elevation with PR depression. And these ST segment elevations are usually concave. So they all look like a saddle. If you look at the ST segments here, they all look like a saddle. So I call it like the pericarditis pony. You can think like if you were riding a pony, you hop on the saddle. So if I see diffuse ST segment elevations, especially in a relatively healthy individual who doesn't have like coronary vascular disease, it's most likely going to be acute pericarditis, especially if I see the PR depression along top it, right? Because if we look at this, almost every single lead is elevated. So that means it's not just a single coronary vascularization, right? It's multiple. That tells me something else is probably going on. Now, what you brought up was electrical alternans, which is most likely seen in pericardial effusion and tamponade. So what can happen is if you have a patient with pretty significant inflammation, we can add to the pericardium, we can get fluid that deposits within the pericardium. And that fluid then compresses the heart. And obviously, well, actually, you tell me, right? So when the fluid compresses the heart, what changes it from pericardial effusion to tamponade? Like, what is cardiac tamponade physiology?
Well, so there's increased pressure within like that pericardial sac. So I guess like the muscle is probably like suppressed. It has less space to like really do its pumping.
Yeah. So in tamponade physiology, there's a lack of forward blood flow throughout, right? The diastolic pressures will equalize within the atria and the ventricles. They're all equal. So there's no pressure gradient to push fluid forward. That's because the blood in the pericardial sac is compressing all four of my heart chambers, and it's causing an equal amount of pressure in each chamber. So there's a lack of forward flow. Remember, tamponade, we can see elevated JVD, we can see muffled heart sounds and hypotension because of lack of forward flow. In pericardial effusion, we haven't progressed to that tamponade physiology yet, right? So there is fluid compressing the heart. There's still able to be forward flow though, okay? So what happens with the electrical alternans is every time the heart beats, it kind of swings within this cardiac sac, right? Within this fluid-filled sac. And as it swings one way or the other, we might be closer or further away from the EKG leads. The closer we are, the higher the QRS voltage will be. And so we'll see one voltage. If we look like down the limb lead or like the lead that shows us like our entire like V5 down here, if we look at it, right, we get a full look. Like this QRS will be tall, this one's short. This one tall, this one's short. So that's electrical alternans. Another thing you might see in effusion is what we call a low QRS voltage. So the vast majority of your EKG leads will have a very small QRS. They'll be like less than a little box, which will be, or sorry, like a bigger box. So like one of these ones. So it'll be less than 0.5 millimeters. So that's something to look out for. That's again because the fluid is kind of in between the EKG lead and my heart. And so the fluid is kind of stopping the EKG lead from picking up the QRS voltage, right? The ventricular depolarization. So no electrical alternans, no low QRS voltage here. So there's probably not an effusion, right? But a classic question that they could ask you, right? So they'll give you this exact vignette and they'll say, what's the next best step in management? And instead of asking about the treatment, like instead of all 4 options or 5 options being treatment, they're going to be more of like diagnostic workups. So in that case, you would do a TTE, right? I'd go look and see if I can see an effusion, right? Because that is something we can kind of work on, right? So what would if I saw an effusion and the patient was symptomatic, what do we do?
Pericardiocentesis.
Yep. And what if they have recurrent pericardial effusions?
Well, I think we need to do something instead of just keep drawing off the fluid.
Yep.
But I
So
remember.
we'll do a subxiphoid pericardiectomy or a pericardial window. We just keep an opening in the pericardium to stop that fluid from draining in. For this patient, right, they have probably viral pericarditis, right? What's the treatment for this patient? For acute pericarditis? How do we treat them?
It's viral. I don't know. There's not much we can do. We got to just do supportive care.
So I'll tell you just in general, what's the treatment for pericarditis?
It's a good question.
No, this is why we're doing this, right? There's so much information you've learned over the last, year in the hospital that it's so hard to remember stuff. That's why we just keep bringing it up, right? So the more we bring it up, the better, the more fresh it stays. So remember, it's going to be NSAIDs and colchicine. Does that sound familiar?
Oh,
NSAIDs and colchicine are going to be go-to. So like things like ibuprofen or indomethacin are usually like the go-to. NSAIDs, and then colchicine, right? How does colchicine work?
Definitely something about inflammation. It's used to gout. So like, what
Yep.
is it doing?
So it's a tubule inhibitor. And it usually works. It favors more of like the neutrophils, so it stops like neutrophil migration, right? When neutrophils are the primary aspect of my immune response, right? That causes the inflammation. So NSAIDs plus or minus colchicine, and then remember colchicine can classically cause really bad diarrhea, so be on the lookout for that. Never pick steroids. Steroids are only used in like refractory cases or cases secondary to autoimmune conditions. For the sake of step 2, I don't think steroids will ever be the right answer for pericarditis. I feel like that's not a fair step 2 question. So really look for NSAIDs and colchicine. All right.
Awesome.
All right. Which of the following murmurs may be auscultated in this patient? So we have a 79-year-old woman. She presents to the ED after a syncopal event. The patient's son witnessed the event and states that his mom collapsed for about 30 seconds and demonstrated a few jerking movements. When she regained consciousness, she was confused for about 5 seconds and then realized what had happened. In the ED, the patient tells you that she has also had some chest pain on exertion and some shortness of breath on exertion as well. An EKG is notable for sinus rhythm and meets criteria for left ventricular hypertrophy and left axis deviation. A TTE is scheduled for the morning. Which of the following murmurs may be best auscultated?
Oh, okay. I'm thinking that it would be the second one with like an aortic stenosis type picture.
Yep. So you're very close, right? So this is aortic stenosis. The problem is B is likely describing aortic regurg. So aortic regurg is a diastolic crescendo decrescendo. It can be heard both at the left and right upper sternal border, whereas the last option, D, is systolic murmur heard best at the right upper sternal border with delayed radiation to the carotids. That's describing aortic stenosis. So that delayed radiation to the carotids is called that pulsus parvus et tardus. With aortic stenosis, right, the more stenotic that valve is, the less forward flow of blood, the more backflow, the more angina the patient is going to experience, right, because their heart's going to have a higher demand and they're going to have less overall flow. There's going to be less oxygenation due to this increased demand. And then the patient could have dyspnea due to a lack of forward flow. The patient could also have syncope, again, due to a lack of forward flow to the brain, right? So the three major symptoms of aortic stenosis are SAD, syncope, angina, dyspnea, all due to really a lack of forward flow and increased demand of oxygenation to the heart. All right, does that make sense?
Yeah.
So classically, you'll see, you can see hypertension, you can see left ventricular hypertrophy, left axis deviation, because the left ventricle is going to get big, big, big to try to compensate, right? So I think that's what I wanted to say on that. So make sure, again, murmurs, super high yield for step 2, right? They never go away. Murmur, murmur, murmur. This holosystolic murmur heard best at the left lower sternal border that increases with inspiration. Do you know which one that is?
Yeah, that should be hokum.
So that could be, yep. I'll actually tell you, yeah. So there could be a couple. So it could be hokum. VSD could also be a holosystolic murmur heard at the left lower sternal border. Tricuspid regurg as well. When you see that it increases with inspiration, that tells me it's more of a right-sided murmur. Okay. When I inspire, it causes negative intrathoracic pressure. It brings more blood to the right side of my heart. If I have tricuspid regurg, we brought more blood to the right side of my heart. It's going to cause that valve to regurg even more. It's going to make that murmur even louder. So when I see a holosystolic murmur, best heard at the left lower sternal border that increases with inspiration, it's most likely tricuspid regurg. This finding, we call it Carvello's sign. Right? There's like a name for it. We already talked about B, and then what's C? Diastolic at the apex.
Mitral stenosis.
Yep, mitral stenosis. And then just for completeness, what might you hear for mitral regurg?
Mitral regurg. So that would be systolic, and then you had the opening click.
Maybe, yep. So like the opening click and the opening snap, you know, you can, yeah, like, so you can hear like the opening click with a mid-systolic murmur would be maybe more mitral valve prolapse. Your mitral stenosis would be like your diastolic rumble with the opening snap, as maybe what you're thinking about. For mitral regurg, it's classically just like a holosystolic murmur heard best at the apex, and it might radiate up to the armpit. Does that sound familiar?
Yes.
So I'll tell you for step 2, there will probably be a question or two, which literally just, hey, do you know what this murmur is? And then there will probably be a question or two where you literally need to listen to the murmur. There's still those questions. I'll tell you, I think there's like maybe 4 of them, probably like 2 or 3 of them. You could read the vignette and be like, I probably already know what's going on if you know your shit. And then you could probably just like listen to it and try to convince yourself, yeah, that sounds like mitral regurg, and just pick it and move on. And then 1 or 2 of them, you'll listen and you'll be like, I have no idea, because like which 3rd-year medical student actually knows like what these murmurs sound like? Very few. All right, so our same patient, she decides to pursue aortic valve replacement. Once the mechanical valve is placed, lifelong anticoagulation with which of the following will be needed?
Oh, it has to be an antiplatelet because it's a foreign body, so apixaban.
Good thought. Yeah, I hate to. It's warfarin. So this one, apixaban and your DOACs have started to be studied. Still don't have great data on them yet. Warfarin is by far still the superior agent for mechanical valve anticoagulation. I will also tell you, be careful with your anticoagulants because apixaban doesn't work on platelets. How does apixaban work?
Okay. It's actually is it a direct thrombin inhibitor?
Very close. It's a direct factor 10 inhibitor. So we have our intrinsic, extrinsic pathway, right? Intrinsic will be 12 11, 9 plus 8, 10, 5, 2, 1. So if we block 10, right, we're blocking the common pathway. And then the extrinsic pathway, we start with factor 3. It activates factor 7. And then we go 10, 5, 2, 1. So we're blocking factor 10. It does have some effect on factor 2, which is thrombin. But like your direct thrombin inhibitors are more of like your dabigatran, argatroban, bivalirudin, fondaparinux, those kind of things. So not really too much of an effect on the platelets. It's more of an effect on secondary hemostasis and your clotting cascade, right? Whereas primary hemostasis platelets, that's more of your aspirin, right? Clopidogrel, things like that. Abciximab, which is a GP2B3A inhibitor. Are those all sounding familiar?
Yeah, they're all familiar, but they all kind of like
Okay, we can go
mix
over
up.
those at a later date too.
Yeah.
Those are very high yield to go over. But what you need to know for your step 2 exam, and honestly, like this would be very important for your like family if you end up going into family med, right? You have a patient who's got a mechanical heart valve. As of right now, they need to be on warfarin for the rest of their life, whether it's aortic, mitral, tricuspid, whatever type of mechanical valve. Warfarin, warfarin, warfarin. We usually try to keep the INR between 2 and 3. There are occasions where we can let it slide up a little bit. Those are far and beyond what you need for step 2. But also, there's so many ways I can spin this question, right? The patient's on warfarin, and again, you have to know we at least want the INR somewhere around 2 to 3, right? What happens if their INR is like 10? Oh shit, we got way too much warfarin. They're at risk for bleeding out. What if their INR is 1? Oh man, now they're at risk for rethrombosis of their mechanical valve, right? So all things to consider. Do you remember how warfarin works?
Okay. Warfarin is, I think it inhibits vitamin K, which is required to activate specific part of the clotting cascade.
Yep.
But
So warfarin blocks vitamin K epoxide reductase, which is really important for gamma carboxylation and reduction of vitamin K. So this VCORC in the liver takes oxidized vitamin K. We throw it through this enzyme. We reduce it. Reduced vitamin K is super duper important as a cofactor to activate factors 2, 7, 9, 10, and protein C and protein S, right? So without warfarin, or sorry, with warfarin, we'll slowly reduce 2, 7, 9, 10 C and S, all right? Remember, all of my clotting factors are made in the liver, except for which one?
I don't know. I think it's made in the kidneys, though.
So factor 8. Factor 8 is made in the endothelium. So we're blocking the production of these liver-made clotting factors here, right? So 2, 7, 9, 10, CNS. And remember, when we start a patient on warfarin, we usually we bridge them, usually with heparin, right? Because oftentimes factor 7 has a very short half-life, and protein C and protein S also have a very short half-life. But there are patients who might have protein C or protein S deficiency. So if I put them on warfarin without putting them on heparin, and they're already deficient in protein C, they're going to lose the rest of their protein C and protein S, and we're going to favor their clotting factors, right? We've lost some of my anti-clotting factors, and we're at risk for big thrombosis, right? Warfarin-induced skin necrosis is what you'll see in those stupid Anki cards and stuff, right? So again, protein C, protein S have a very quick half-life. C plus S come together. They block factors 5 and factor 8. All right. So you can think about factor 5 Leiden, story for another day. But then proteins or factor 7 has the shortest half-life of all the clotting factors. And 7 we track with the prothrombin time. So again, the way we look for warfarin is it working, right? We look at their PT and their INR. Does that make sense?
Yes.
Long-winded, but again, mechanical valves, warfarin, look at their PT and their INR. All right. So we've now put a mechanical valve in the aortic valve for this patient. She asks you, hey, I'm going to the dentist for a routine cleaning. Does she need infective endocarditis prophylaxis?
Yes.
Okay. What if she just had her aortic stenosis, no mechanical valve? Does she need it?
No.
What if she had mitral valve prolapse?
Yes.
Okay. So, yeah, this is a very tricky one. So, I will tell you mechanical valve, yes. Aortic stenosis, no. Mitral valve prolapse, no. All right. There's very specific indications for infective endocarditis prophylaxis, and we'll talk about them in a second. Any question about anything we've talked about so far?
Okay, this is random, but I had an intern tell me that actually the murmur isn't that correlated with the location. Is that like true or
I would say like there's some truth to that. For the sake of STEP, for these standardized board exams, it's going to be like that. But yeah, I would say there's some truth to that. Absolutely.
okay.
Right. And honestly, like if you have any suspicion of any kind of like thing going on with the heart, you're going to get an EKG and you're going to get an echo. So you'll see it anyways. So catching a murmur isn't always like the end all be all. All right. So, oh, I forgot to ask. If you want to give the patient prophylaxis, what do we give?
Amoxicillin.
Yep, amoxicillin. Remember, if they're allergic to amoxicillin, we can use things like a macrolide or clindamycin. But amoxicillin, this is the way they'll ask it: is does the patient need prophylaxis? Yes or no? And what do they need? They need amoxicillin. So indications: prior history of infective endocarditis, mechanical or prosthetic heart valve, cardiac transplant with residual valvopathy, a congenital heart defect, and a repaired congenital heart defect with a residual shunt. Those are my indications for infective endocarditis. The way they'll get you is they'll give you a patient with mitral regurg or mitral valve prolapse or tricuspid regurg, and they'll say, does this patient need infective endocarditis prophylaxis? And you say, absolutely not, go, right? Again, prior history of IE, mechanical or prosthetic valve, they got a heart transplant but still have some sort of valvulopathy, they have a congenital heart defect, or they have a repaired congenital heart defect but still with a residual shunt. Other thing I forgot to mention, what would you think if you had, so our last patient, she was like a 75-year-old with aortic stenosis. What if this was like a 50-year-old with aortic stenosis? What could cause that? So remember, like aortic stenosis usually occurs from calcification of the valve that takes decades on decades on decades. Like usually we'll see patients in like their late 60s, 70s starting to show up with this aortic stenosis. If I see someone in their early 50s, I think about bicuspid aortic valve, right? Bicuspid aortic valve predisposes you to early onset aortic stenosis because the valve isn't set up right. It's just set up to be really stiff, right? Are there any diseases or one particular disease that you should be familiar with that is commonly linked to bicuspid aortic valve? In fact, bicuspid aortic valve is the most common cardiac defect in these patients with this disease.
Hmm.
Let's see
Maybe
there. I'll go ahead.
maybe Down syndrome or to George.
You're close. You're on the right track. We'll say they're 4'8" female. They've got a short hairline. They've got a web neck.
No,
Have
Turner
I given you
syndrome.
enough? Turner syndrome, right?
No.
45XO. The most common cardiac defect in these patients is bicuspid aortic valve. All right. All this making sense?
Mhm.
All right. Um, I think I have further questions on infective endocarditis, so I won't ask them now. All right. Our patient also, so let's say our same patient, right? She also had stable angina. In general, what are medication management strategies for stable angina? We've talked about one of them. I mentioned it at the beginning.
Beta blocker,
Yep. So beta blockers are first line. There's another first line agent.
nitroglycerin.
Yeah. So nitro, I kind of consider like a 1A, because that's like sublingual nitro is gonna be kind of like more of a work now, but it's not like kind of a long-term strategy. Um, we can use. Do you have any other ideas?
Probably start them on aspirin.
Yep, aspirin. So aspirin, statin, always, right? Aspirin and statin. Beta blocker and calcium channel blockers for symptoms. Sublingual nitro can also be used for symptoms. Long-acting nitroglycerin, so like your isosorbide, mono, and dinitrate, can also be used. And then if all else fails, we can use ranelazine, all right, which is a sodium channel blocker. So really, the way you'll see it in a question, right? Patient with stable angina, and they'll say, what should we put the patient on, right? If they got aspirin, statin, put them on that, right? If they're talking more, if the answer choices are more symptom-based, beta blockers and CCBs, right? Let's say the patient's already on a beta blocker, and they're like, what's next, right? We could add a CCB. We could add a nitroglycerin, right? Then the way they'll get you is they'll have the patient on metoprolol, they'll have them on an aspirin and statin. Their heart rate will be like 58. Their blood pressure will be like upper 90s over, 70s. Like, so they're like borderline hypotensive and they're bradycardic, and they're still having stable angina symptoms. And they'll ask, what's next? When you get that type of patient, that's when you consider ranelazine instead of starting a CCB or nitroglycerin, because these can cause further decreasing of, this one will further decrease your heart rate to an extent. It can further cause hypotension. This one can further cause hypotension, right? Ranelazine doesn't. Ranelazine will just treat the symptoms. Does that make sense?
Yeah.
All right. So you nailed it on the head. Aspirin, statin, beta blocker, CCB, nitroglycerin, ranelazine. All right. So with regards to infective endocarditis moving forward, what's the next best step if you think someone has infective endocarditis? You get 3 sets of blood cultures, you start them on empiric antibiotics, and you get I should say a TEE, or sorry, no, TTE, but you don't see any vegetation. So I was right the first time.
See, well, then I think we have to do a TEE
Yeah.
to see the valves that are.
I gave it away. But yeah, so if you get a TTE first and you don't see it, right? And there's still suspicion for infective endocarditis. Next step is to get the TEE. We go through the esophagus, we get a better look at the aorta and the mitral valve, right? So we can possibly see those vegetations, right? So that's always the right answer, right? TTE unrevealing, go get a TEE, transesophageal echo, right? So what if you confirm that the patient has infective endocarditis with gram-positive cocci and clusters that are coagulase positive and sensitive to vancomycin? We treat the patient with vancomycin. We get the vancomycin trough. It's in an appropriate range, so we know we have the right dose, but the patient isn't getting better. Telemetry picks up a new second-degree type 2 AV block. What now?
Oh, I bet that's a drug side effect of vancomycin.
Good thought, but probably not. Like, so vanco is going to be really nephrotoxic, not so much what's going on here. So you need to kind of explain, right? The cultures we got showed that this bug is susceptible to vancomycin. We have the proper dose, right? The trough's in the right range, but it's not working, and they have a new heart block.
Mm-mm.
So this is when you consider a perivalvular abscess, okay? So really, like, you've probably thought about this for like pyelonephritis. If you have a patient with pyelonephritis, we treat them with IV ceftriaxone or, whatever other antibiotic regimen we're doing. And after 48 hours they're not getting better, what do you think about? You think about a perinephric abscess, or you think about some sort of kidney abscess, right? And right? Did this ever come up on internal med? Or do you ever talk about it?
We definitely had a patient with a perivalvular abscess, but I was.
Yeah.
just the
And so it's
management after.
yes, it's the same idea. Is the bug set up shop on one of the valves and it formed an abscess. And when it's got an abscess, it's kind of walled itself off from the antibiotics. So in this case, let's get re-imaging. Let's find the abscess, and we're going to need to surgically remove it. You'll often see with these perivalvular abscess some sort of new heart block. That's because they usually impact the AV node in some way. They kind of extend into the AV node. So long story short, infective endocarditis, not getting better with the right drug, and new complete heart block or new some sort of heart block, think about perivalvular abscess. We image, we find it, we surgically remove it. Make sense?
Yep.
All right. Which of the following is the most appropriate initial management for the arrhythmia? 68-year-old man presents to the ED with palpitations and mild dyspnea. His EKG shows AFib with a ventricular rate of 140. He is alert, normotensive, and has no signs of heart failure. His echo from last month showed an ejection fraction of 55. How do we treat it?
Okay. We're gonna go with IV amiodarone.
So amiodarone can be used for AFib. It's usually not first line because of the side effects.
Okay, well, I don't think he needs cardioversion because he's not unstable
Good.
or anything. Except digoxin is never the answer, so
Correct.
not that. Magnesium does do something. I don't really remember.
It does do something.
And then I have a calcium channel blocker. I don't think that's so much with AFib, so I'll just go with E.
So the right answer is your calcium channel blocker. So first line for stable AFib, right, is going to be usually rate control. Sometimes we can do rhythm control. The debate is still up for grabs, but rate control is going to be with a beta blocker or with diltiazem, right? So it's usually metoprolol or diltiazem, right? Does that make sense? So
Okay.
we'll get the rate under control with IV metoprolol or IV diltiazem. You have to be careful. This is probably more of a step 3 concept or beyond. If the ejection fraction is less than 40, we don't use IV diltiazem because that has negative inotropic effects. So in that case, we can use metoprolol or we can use digoxin. Story for another day. Stable AFib, we want to get the rate under control. IV metoprolol or IV diltiazem. Amiodarone, too many side effects for it to be first line. Too many side effects for it to be first line. You already told me they're hemodynamically stable. Magnesium is used in terms of heart in torsades de pointe, so which is a polymorphic ventricular tachycardia that can help restabilize my ventricular rhythm or my cardiac membrane, basically, to stop that from progressing to VFib and cardiac death. All right. So I kind of, and again, I'll send you these slides so you can kind of read a little bit more. But all these different societies all recommend beta blockers or non-dihydropyridine calcium channel blockers, such as diltiazem or verapamil as first lines. We already talked about these calcium or this caveat. All right. Next question. So again, first line AFib, hemodynamically stable, IV metoprolol, IV diltiazem, or IV beta blocker, IV calcium channel blocker. Here we're thinking about what's the next best step in management. We have a 65-year-old female. They present to the ED with palpitations that have persisted over the last few days. The EKG is notable for an irregular pattern with a ventricular rate of 140 beats per minute. The patient states that she has never had symptoms like this before. She notes she does have a history of well-controlled HFrEF and hypertension. She cannot recall when these palpitations started, but she thinks it was within the last 4 to 5 days. She's currently hemodynamically stable. She opts to do electrical cardioversion for the management of her newly diagnosed AFib. What is the next best step in management?
Okay. I am not that familiar with AFib, but there's like the thing is we don't know how long she has had the
Yep.
AFib, so she could have already made a clot, and if we just cardio convert her, then the clot goes to the brain, we have a stroke. So I think it's we're gonna check and see if she has that, and then we can cardiovert.
Yep. Did you say C or D? Do you think she needs a Pixaban?
Oh, oh, if we cardiovert her, then she shouldn't need a Pixaban, so it should actually be D.
You don't think she needs a Pixaban?
Well, if she doesn't have AFib anymore.
Does cardioverting like completely get rid of AFib?
I don't know. I would think you would monitor for it and see if it's
Yeah.
still there or not.
So catheter ablation is kind of considered like ablating, right? We usually go to the pulmonary veins and ablate that abnormal foci. Um, that's kind of more or less curative. It's not like I won't use the word curative, but more or less. Direct cardioversion is kind of just to get the heart rate under control. It doesn't necessarily get rid of the AFib. So one, I'll tell you absolutely right. Getting it down to C and D, perfect, right? We want to do a transesophageal echocardiogram, right? So indications to get a TEE before direct cardioversion is if the AFib has an unknown duration or has been at least for over 48 hours, right? Over 2 days, all right? That's because, again, exactly what you said. They could have a thrombus that usually forms in the left atrial appendage. If I do this direct shock to the heart, it can cause a really strong contraction, remove that clot. It goes right up to the carotids, right up to the brain. So we want to do a TEE first to check and make sure there's no clot there before I direct cardiovert them. Or if we don't want to do the TEE, I can put them on a Pixaban for 3 weeks minimum and then do the direct cardioversion without doing the TEE. Does that make sense? So AFib of unknown duration or over 48 hours, we either put them on anticoagulation for at least 3 weeks and then direct cardiovert them if they want it, or we do a TEE now and direct cardiovert them if they want it. Now, to decide if the patient needs long-term anticoagulation, we use the CHADS-VASc score, right? That's the probably still one of the most validated. There's some other scores there. For the sake of step 2, they're never going to be like, hey, what is this patient's CHADS-VASc score, right? And like give you A through D and they're all numbers, right? But you should be able to just like quickly say, right, does this patient need anticoagulation or not, right? Usually what the literature says is if a man has a score of 2 or more, that's indication. If a woman has a score of 3 or more, that's indication, right? So she's 65, that gets her 1 point. She's a female, that gets her 2 points, right? So she's already at 3, and we can kind of just keep going. She has HFrEF and hypertension, 2 more points there, right? We don't know anything about stroke history or diabetes or vascular disease. I don't need to know that. She's well above the 3 points. Put her on a Pixaban. Does that make sense?
Mm-hmm.
All right. We usually put patients on 5 milligrams twice a day. Maybe not so much for step 2, but if the patient is over the age 80 or older, they're a weight of less than 60 kilograms, and they have a creatinine greater than 1.5. If they have just 2 of those or more, or if they have all 3, that's indication to drop their Pixaban to 2.5 twice a day. That's probably not needed for step 2, but just for your knowledge. All right. You'll see that on Family Med for sure. You have patients who are on the wrong doses of meds that you'll need to fix. All right. If the patient has pulseless VTAC or ventricular fibrillation, what do we do next?
Okay. I think first you can give meds.
So these are like medical emergencies. We got to act.
Right. Okay. Are we just shocking them?
Yep. So
Defibrillating?
pulseless VTAC and ventricular fibrillation are what we call shockable rhythms. We'll do unsynchronized cardioversion or defibrillation, right? So AFib we can hemodynamically unstable AFib, we can do direct cardioversion or synchronized cardioversion because we can still synchronize to the QRS, okay? And we can hit that shock right on the QRS to kind of bring us back. When you have a patient who has pulses VTAC or ventricular fibrillation, there's not really like an underlying rhythm. So we don't have anything to synchronize to. So we do unsynchronized defib, right? We can, though, eventually give drugs like epinephrine, amiodarone, lidocaine, okay? First things first are going to be defib and CPR, and then we can move to the drugs while we're still cycling through the CPR and the defibrillation, right? But really, you're reading an exam question, you see the EKG that's VFib, or they tell you it's pulses VTAC. What do you do next? Synchronized unsynchronized cardioversion or defibrillation. All right, makes sense?
Mhm.
So now, what if the patient has sustained VTAC, so it's been going on for over 30 seconds, and they have a pulse and they're hemodynamically stable? Now is when you can give drugs. So which drugs do we give? What's the gold standard?
I think it's amiodarone.
So amiodarone used to be gold standard. Now it's procanamide. Um, I will tell you though, sometimes the board exams are slow to catch up. So amiodarone could still absolutely show up. Sotalol, lidocaine, and again, only one of these could be presented as an option. So if you're kind of familiar with all of them, you'll be totally fine. Remember, procanamide is a 1A inhibitor. Amiodarone is more of a class 3, but it kind of hits all of the classes. Sotalol is a class 3 and a little bit of class 2, and lidocaine is a class 1B antiarrhythmic. Tell me really quick, what are the side effects of amiodarone that we should watch out for? What do we check on a patient before and during treatment with amiodarone?
I don't know.
So it's PFTs, TFTs, and LFTs, right? Pulmonary function test, because it can cause a restrictive pulmonary fibrosis, restrictive lung disease. We check liver enzymes because it can cause hepatocellular damage. And then we check their TFTs, their TSH and T4, because it can cause both hyper and hypothyroidism. That one's super high yield, right? That's very, very important. All right. We're almost done. What do we do if the patient has no pulse, but they have electrical activity on EKG? And what do we do if they're in asystole? So the management's the same. So we call this pulseless electrical activity, the PEA, and then this asystole. What do we do?
So these are not shockable rhythms, but we want
Absolutely.
to get them into a shockable rhythm.
Yep.
So then medication,
So,
probably epinephrine,
yep.
amiodarone.
So we're going to do CPR, and eventually we can do the epinephrine, amiodarone. But again, so like right answer would be CPR in these, right? These are not shockables. We want to look for the 5 H's and the 5 T's. So hypovolemia, hypoxia, hydrogen ion, so acidosis, hyperkalemia, hypothermia, toxins, tamponade, tension, pneumo, and thrombosis and trauma. Those are all causes of PEA and asystole. Might be beyond the step 2 land, because the questions that might make the question too in depth. But really, PEA and asystole, CPR, not shockable. Ventricular fibrillation, pulses VTAC, defibrillation, right? Those are shockable. All right. So again, like the key point, neither rhythms are shockable. All right. Management of the following EKG findings. So think about on the top one, what would we do? And then we'll move to the bottom one.
Oh my gosh, I'm so bad at EKGs.
Oh,
Okay.
that's right. This is really good though, because it's identifying a weakness early, and you have multiple months to practice. So
Yeah. So it doesn't really, I Okay, just like on a quick glance, it doesn't really seem that even, maybe. But it's not, okay, it's not like an obvious heart block, though. It's about 1.5 between each, so that's not probably it.
So, like again, it's easier when you have the full rhythm strip or like the full EKG. This is just the rhythm strip to look at. But what I do, like first things first, I look at the rate, rhythm, axis. I can look at the rate. I can look at the rhythm. We can't look at the axis here because I don't have the full EKG. But really, this would be like you can just do like the counting, but this would be 300, 150, 100, 75. This so like it's a rate of about 60. You can do like there's multiple ways to calculate it. And this looks to be regular, right? It looks like it's marching off regular. And then is there a P before every QRS? This
Yeah.
one's kind of hard to see, but yep, 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 yep. Is there a QRS after every P? Yep. Are the P's upright in leads 1 and 2? I don't have lead 1. This is lead 2. Yes. Is it down in AVR? Yep. Then that's going to be regular sinus rhythm. So we've got all that. But then what I need to do is I need to start looking at my intervals, right? My QRS should be less than 0.12, so less than three little boxes, which they all look to be. So that's narrow. But then what's weird here is the PR interval should be really less than 0.5. It should be really anywhere between 0.3 and 0.5, which is just one of these, like, so one of these boxes right here. Like, so one of the bigger boxes is 0.5. So if you look, it kind of starts here. This one starts right on the line, and it goes all the way past the other line here. So that's a prolonged PR interval, right? But we've never dropped a beat. So a prolonged PR interval with no drop beats is first degree AV block. Right?
Okay.
So how do I treat that?
Gonna do some type of medication.
First degree AV block is completely benign. Don't do anything. Observe.
Yeah.
Right. So key point on these like questions, because you will get at least one, if not more than one, where they'll give you some sort of EKG and be like, what's the next best step? You don't necessarily need to know the exact diagnosis. You just need to know, do I observe or do I put a pacemaker in, right? Those are really for the AV blocks, right? Really giving a patient like something like atropine wouldn't be a great option for someone who has like complete heart block because their AV node is already blocked. Giving them atropine is not going to really do anything. I need to put a pacemaker in, right? They'll often put atropine as an answer because students will pick it because they know it's used for symptomatic bradycardia. But if they have symptomatic bradycardia because of AV nodal blockade, giving them atropine is not going to do anything, right? All right. So now take a look at this bottom one and see how it's different.
Okay, so this one, we have the PR interval is prolonging. There's no drop beat though. So this would be type 2 heart block 2A.
Yeah, these ones are hard. So this is actually an example of complete heart block or third degree. So really what I do is I look at all the QRSs and they seem to be marching off appropriately, right at the same rate. Then I look at the PR interval or the P. Here's a P here. And if I count over 1, 2, 3, there's another one. 1, 2, 3, there's another one. Okay, 1, 2, 3. Do you see this little bump here? That's abnormal, right? So if I look at this T wave, that's what a normal T wave looks like. This looks abnormal to me. That's because there's a P wave hidden here. 1, 2, 3, there's another one. 1, 2, 3, there must be a P wave hidden somewhere in here. 1, 2, 3, there's another one. And it keeps going. And see, there's another one hidden in that T wave. So the PR intervals or the P's are all marching out at their beat. The QRSs are all marching out at their beat, and there's a blockade between them. They're not communicating to each other. So there is actually drop beats, right? Is there a QRS before or a QRS after every P, a P before every QRS? No, because look at, we've got this one here. I don't see any QRS. We've got this one here. I don't see any QRS. We've got this one here. I don't see any QRS, right? I can give you many more examples. So this is an example of third degree heart block. But again, even if I didn't know, is this an example of third degree or is this second degree type 2? I can't remember. Pacemaker, right? Pacemaker, pacemaker, pacemaker. So first degree heart block, monitor. Third degree pacemaker. If it's second degree type 1, where it's longer drop, we can also just monitor. If it's second degree type 2, where the PR interval is constant, and then we drop, we need to put a pacemaker in. Does that all sound familiar? I've got examples of those coming up in a second. All right. What do we do if we have a patient, they're from Connecticut, they come to our clinic after a syncopal episode. They tell you they've had joint pains for the last 2 months, which started promptly after noticing an annular rash in their thigh. The EKG is notable for second degree type 2 AV block.
Great. They have Lyme disease, so we're going to treat them for that with doxycycline. And oh, wait, does doxycycline cover if it's
good
submitted? It might have to be, okay. That's because I only remembered doxy, but now I remember that you can also use ceftriaxone.
Yep.
And that's stronger.
So, yep. Doxy is the go-to for non-cardiac and non-neuro Lyme. So if the patient just has like Lyme, that's joint rash, usually doxy will be good. If we've got Lyme carditis or neuro Lyme, we need to use IV ceftriaxone. All right. You got to be careful here because they'll present both doxy and ceftriaxone as options. So be careful. If it's a little kid, if it's a kid less than 8 with just regular Lyme, we usually don't like to use doxy. We'll use something like amoxicillin instead. So that's like an instant because doxy can stain the teeth. So it's not the best for little kids. The exception to that rule would be something like Rocky Mountain spotted fever, where we give everyone doxycycline. All right, I don't care if they're 5 years old or if they're 50 years old. We give them doxy because that one's extremely deadly. But you're absolutely right. Right, Lyme carditis, we can't do oral doxy. We need to do IV ceftriaxone. We don't necessarily need to put a pacemaker on this patient right away. I'm going to treat them with the IV ceftriaxone. We'll see if their heart rhythm gets better, and then we can decide from there, do we need a pacemaker? All right? Okay, just a few more. 58-year-old man with poorly controlled hypertension presents to the ED with severe chest pain. He states he also feels like his upper back is on fire. His vitals are notable for a BP of 180/90. That's equal in both arms. Heart rate 110, respiratory rate 15. SpO2 is 95% on room air. Auscultation of the heart is notable for a diastolic crescendo murmur, heard best at the left upper sternal border. What is next best step in terms of imaging?
Well, I'm thinking that this is an aortic dissection and we should get a CT chest.
Yep. Can you be more specific?
Well, if we're hearing the murmur, and it's likely a type A near the aortic root. You mean CT with contrast?
So yeah, you want to get a CT angiogram, right? To look at the actual arteries, right? Very good. Would have gotten it right on a board exam for sure. So if they are stable, CTA. If they are unstable, so like a blood pressure systolic less than 90, or they're altered mentally, right? We want to get a TEE on the way to or in the operating room, right? So stable CTA, unstable TEE. All right. So let's say on any patient, it really doesn't matter. We see this on the CTA. how would you classify this type of aortic dissection? And what do you want to do next?
Okay. Well, classify it as type A over here in the ascending aorta, and that should be surgically intervened on, call cardiothoracic surgery.
So you're absolutely right. The one problem is this is the descending aorta, and this is the ascending
Right.
aorta. So you are absolutely right. No, totally fine. Totally fine. Ascending aorta, absolute medical emergency, call cardiothoracic. Descending, right, distal to the subclavian in the descending aorta, Sanford type B, we usually do medical management, right? So what would your medical management be for this patient?
Beta blockers.
Yep. So beta blocker like esmolol is going to be your first line. CCBs like non-dihydro CCBs can be used. If those fail, we can consider nitroprusside. You want to watch out for cyanide toxicity, right? So the patient might give you a stem where the patient gets nitroprusside. They all of a sudden go into acute hypoxemic respiratory failure. Their face gets a little ruddy. Maybe they have almond breath. You think about cyanide toxicity. So those are things to consider. We want to get the systolic blood pressure less than 120, the heart rate less than 60. If it's an ascending, get them to surgery ASAP. Does that all make sense?
Yes.
All right. I guess I don't have pictures of the other heart blocks. So let me just go back over them real quick. So first degree is a long PR interval, so greater than one big box with no drop beats. We just monitor. Second degree type 1 is the PR interval gets longer, 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 and eventually we drop a beat, right? It doesn't have to be like 3 longers and then a drop. It's just, it gets longer, 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 and eventually we lose a beat. For that one, again, just monitor. If it's second degree type 2, the PR intervals say stable, 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 and then we lose one. All right. That we need to put a pacemaker in. And then complete heart block would be the P's are talking to each other, the QRSs are talking to each other, but they're not talking amongst each other. That's a pacemaker as well. All right. I've got like one or two more. Okay. Complications of aortic dissection. We already saw it in the stem. Aortic regurg, if we're impacting the aortic root. We can get cardiac tamponade if the dissection extends into the pericardium. So be on the lookout for muffled heart sounds, hypotension, JVD. We can get stroke if we impact the carotids. And then we can see the BP mismatch in the arms if we impact the left subclavian. Right? Does that make sense?
Mm-hmm.
All things to look out for. All right. Which of the following is the most appropriate next step to confirm the diagnosis? We have a 68-year-old man with a 40-pack year smoking history, hypertension, and hyperlipidemia. They present with exertional left calf pain that resolves within 5 minutes of rest. He denies pain at rest. On exam, femoral pulses are palpable bilaterally, but the left dorsalis pedis and posterior tibialis pulses are diminished compared to the right. There are no lower extremity ulcers. What do we do to confirm this diagnosis?
ABIs.
Absolutely, right? So this should scream at you, peripheral arterial disease. We need to get an ABI, right? So we get a blood pressure cuff. We put it on the ankle. We put it on the brachial artery. We compare them. We take the ankle divided by the brachial. If that value is less than 0.9, that's sufficient to diagnose PAD. If it's a high value, usually above 1.2, 1.3, it tells me the artery is non-compressible and there's likely calcification in there. Other things to consider, maybe the ABI comes back normal, but we still have a high suspicion for PAD. We do what's called an exercise ABI. It's exactly what it sounds like. We have the patient exercise immediately after we do the ABI. It'll likely come back abnormal. All right. So let's say the ABI on the left side comes back at 0.65. What should we do for treatment?
Say medical management, aspirin, statin, exercise program.
Yep, 100%. So everyone gets smoking cessation, everyone gets supervised exercise, and then we can consider everyone's going to be put on aspirin. They're going to be put on a statin. There's new data that shows rivaroxaban with the aspirin is also pretty effective as well. Probably too early for that to show up on STEP. If they also need something a little bit more, this silastazole, which is a PDE inhibitor, like a phosphodiesterase inhibitor, has also shown effective. And then if they fail everything, that's when we consider revascularization. But again, we diagnose them with peripheral arterial disease, smoking cessation, exercise therapy, aspirin, and a statin. Everyone gets that. And then we can consider silastazole, maybe a rivaroxaban, and then if they fail all that, revascularization. Very good. Last question. What are indications to get imaging to screen for AAA? What type of imaging should we get for this screening? And what are indications for surgery?
So all men who have ever smoked from
Yep.
age 65, starting at age 65. Also, okay, somebody who, so there's not as strict of like guidelines for women. The literature isn't there, but if they have a history of smoking, you should probably also image them for aortic aneurysm. Of course, like if you do a physical exam, you feel like you can feel palpable, like pulse
Yep.
in the abdomen, then you should go ahead with imaging if you hear like brewy or whatnot. So then it would be an abdominal ultrasound. Yeah. And
Yep.
then for surgery, well, so it'll be like you'll probably get a CTA on it. And then once it's greater than 5 centimeters for women, greater than 5.5 for men, you will probably intervene with surgery.
Absolutely. I loved all of that. So really it's a grade B recommendation for any male smoker 65 to 75. They consider a male smoker 100 cigarettes or more. That's just like, who cares about the details? They'll give you someone who has like a 40 pack year history of smoking. They're 67 years old. It's a male. You get abdominal ultrasound, right? Abdominal ultrasound is the imaging we do for screening. But again, I agree with you. CTA is going to be better, but we don't need to put everyone through radiation. We can do abdominal ultrasound for screening. Women who have smoked usually get like a grade C recommendation. We can, so like it's like hit or miss. Again, I agree with you. Shared decision making. And then family history of AAA is also shared decision making. But again, your buzzwords for the exam: older male smoker, over 65, you're going to want to get a AAA or abdominal ultrasound. And then indications for surgery. I loved it. You even separated the women and the men. Most people don't even know the distinction. Women, we draw the cutoff at 5 centimeters, men 5.5. And then you also want to consider if the aneurysm has grown by more than half a centimeter in 6 months, or a centimeter in a whole year. That's also indication, because it's fast growing, right? So half a centimeter in 6 months or a full centimeter in a year. And then obviously if it's symptomatic too, would all be reasons to intervene. So that one, perfect. That's that family med. You know your guidelines very well. All right, so that's what I got. I'll stop recording. Honestly, you did